You're sitting in a hospital bed, maybe the ER, maybe you've just been admitted, maybe you're in an outpatient clinic before a scheduled treatment, and a nurse walks in and says you need an IV. A tourniquet goes around your arm, they look at your hand and forearm, feel along your skin, choose a spot. Then the needle. For some people, that first attempt works immediately. For others, it doesn't. And now you're wondering, why can't they find my vein? And how many times are they actually going to try? Here's the detail that changes how this whole thing makes sense. The needle isn't what stays in your arm. It's just the tool used to guide a small, flexible catheter into the vein. Once that catheter is in place, the needle comes out immediately and goes into a sharps container. What's left inside you is just soft plastic tubing, connected to a line that can deliver fluids, medication, blood products, or contrast for certain imaging tests.
My Patient Guide. If this is helping you, you are welcome to subscribe for the day you or someone you love needs answers.
So when someone says you need an IV, they're telling you your team needs reliable access to a vein, whatever the reason for your visit turns out to be. Where you are changes the pace, not the process. In the ER, it might go in while the team is still figuring out what's wrong with you, sometimes before you've even finished registration if things need to move quickly. If you're being admitted, it's usually one of the first things that happens as your treatment gets started. In an outpatient setting, it's placed ahead of a scheduled medication, infusion, or imaging exam. The reason changes. The basic goal, reliable access to your bloodstream, doesn't. If needles genuinely make you anxious, that's worth mentioning out loud before anyone reaches for a tourniquet, not something to just push through silently. Telling the nurse lets them explain each step as they go, which for a lot of people makes a real difference in how the whole thing feels. Before the needle ever touches your skin, a nurse verifies your name and date of birth, sometimes more than once. That's a deliberate safety check, not forgetfulness. Then they lay out supplies, the catheter itself, tubing, a saline flush, a dressing, and a sharps container nearby. The tourniquet goes on first, tightened around your upper arm to slow blood return and make your veins easier to find. You'll usually feel pressure or tightness around your arm. Then comes the part that can look like nothing's happening. The nurse looking at your skin, asking you to open and close your hand, gently feeling along your arm. This is actually one of the most important steps. A vein that's easy to see isn't always the easiest one to access, so they're weighing location, size, and what the IV needs to be used for before they commit to a spot. Once a site is chosen, your skin gets cleaned with an antiseptic. You may feel it cool or slightly wet. Then you're asked to hold still while the needle goes in. Most people describe a quick pinch or sting, sometimes more pressure than pain, and it genuinely varies person to person and site to site. The needle enters, the catheter advances into the vein, and the needle is withdrawn almost immediately. Often before you've fully registered, it's gone. What's left is just the soft catheter, which gets flushed with saline. You might feel a brief cool sensation, then secured under a clear dressing. Now, the part most people actually came here for. If the first attempt doesn't work, the nurse withdraws the catheter and reaches for another one, and this is exactly the moment anxiety spikes. Here's what's actually happening. There are real, common reasons a vein doesn't cooperate. It might be small, sit deeper under the skin than expected, roll away from the needle, or simply not be visible or easy to feel, especially if you're dehydrated, have had a lot of IVs before, or have certain medical conditions. None of that means anyone did anything wrong, and it doesn't mean your veins are damaged. It just means reliable access is taking more effort than usual. If you've ever been called a hard stick, that's what it means, nothing more. And there's a real answer to how many times they'll try. Many hospitals use 2 attempts per clinician as a point to reassess or escalate, but there's no single nationwide rule that applies to every hospital. After that, a different nurse may take over, a different site may be chosen, or for genuinely difficult access, ultrasound guidance may be used, a small probe placed against your skin that lets the clinician see the vein beneath the surface, instead of relying on sight and touch alone. It doesn't make the process painless. There's still a needle, but it can meaningfully improve first attempt success for patients whose veins are hard to access the usual way. None of this is automatic for every difficult IV. It depends on your situation, what's available, and who's trained to use it. But it exists specifically for moments like this. If you already know from past experience that you're a hard stick, say so before the first attempt, not after the second failed one. You can also ask what they're doing, whether another clinician is available, or whether ultrasound guidance is an option. The clinical decision is still theirs to make, but knowing what's happening tends to make the whole thing feel far less like it's happening to you, and more like something you understand. Once the IV is working, it doesn't just get left alone. Staff check the site throughout your visit for swelling, redness, or leaking, and you should speak up if the area starts to hurt, burn, swell, or feel unusually cool while something's being infused. Sometimes fluid can escape into the surrounding tissue instead of staying in the vein, called infiltration, and certain medications can cause a more serious version of this called extravasation. These complications are uncommon, but they're exactly why the site keeps getting checked rather than just placed and forgotten. When you no longer need it, whether you're discharged from the ER or finishing treatment, removal is simple. The dressing comes off, the catheter slides out, brief pressure if needed, a small bandage after. You might have a little tenderness or bruising, especially if it took more than one try, and then it's over. On cost, there's genuinely no single number here. An IV is usually part of a larger medical encounter, rather than something with one simple price: an ER evaluation, labs, imaging, medications, facility fees, whatever treatment you actually received, and your specific responsibility depends on your insurance, deductible, and co-insurance. What's worth knowing? U.S. hospitals are required to make standard charge information publicly available. Though your negotiated rate through insurance is usually very different from that listed price, your insurer's cost estimate tools can give you a more realistic idea of what you may actually owe. And if you're receiving emergency care, Federal No Surprises Act protections generally prevent surprise out-of-network billing for covered emergency services for most people with private insurance, though there are exceptions and it doesn't cover every type of plan. Either way, in an actual emergency, the priority is getting the access your team needs, not comparison shopping for a needle. So here's what you're actually walking in knowing now. The needle isn't what stays in your arm, the catheter is. A first attempt failure can happen, especially when IV access is difficult, and it doesn't mean something's wrong with you or the person trying. Many hospitals reassess after 2 tries per clinician rather than just continuing the same approach. And if it takes more than one attempt, that doesn't automatically mean something went wrong. Sometimes the challenge is simply getting reliable access to a vein that's difficult to see, feel, or safely reach.
This video is for general educational purposes only and reflects a typical patient experience. It is not personal medical advice and does not replace guidance from your own doctor or care team. Protocols vary by hospital and individual case. Always follow your specific instructions. For medical emergency, call 911 or go to your nearest ER.